Now it's my pleasure to introduce our speakers, Dr. Matt Angelidis. He's the co-medical director for the Colorado Springs Fire Department and AMR, and is an emergency physician for UCHealth at Memorial Central, Memorial North, and Pikes Peak Regional Hospital. Also with him is James McLaughlin. He's director of Community Paramedicine at UPass Regional Health Service District. And with that, gentlemen, the floor is yours.
Good morning, everyone. Thank you for that excellent introduction. As Jeff mentioned, I'm Matt Angelidis. I'm an emergency medicine physician and EMS medical director here in Colorado Springs, and I'm joined by...
This is James McLaughlin with UPass Regional Health Service District, and I'm the director of the Community Paramedicine program. We cover 539 square miles of mostly rural and forest area, about 30 miles west of Colorado Springs.
So with that introduction, guys, what I would like to do is kind of present to you a summary of a problem. So as the COVID-19 pandemic has stricken our nation, we in the emergency medicine and pre-hospital world were faced with a new set of problems and a new set of tasks to try and provide efficient and appropriate safe medical care for our patients. In addition to that, around the same time that COVID-19 began to take hold of our country, programs like ET3 were put into place by CMS that allow EMS agencies to bill, code, and collect for alternate destinations. One of the premier alternate destinations that we envisioned in our community was telehealth or telemedicine, a fantastic solution for both the COVID problem and as an alternate destination for ET3. To summarize this concept, we know that about a third of the patients that dial 911 don't actually require emergent intervention, treatment, or transport to an emergency department. We also know that roughly 1 in 5 patients that utilize 911 are repeat callers. They've already been evaluated, treated, or taken to an emergency department. And then lastly, kind of bringing that or tying that back into COVID-19, we know that most patients that develop COVID-19 don't require emergency department treatment, 911 or EMS response or transport. And in most systems across the country, we know that when a patient calls 911, that invariably ends with the patient being transported to emergency department. So in our community, as we were sort of a later developer of COVID-19, we got to watch what happened in Italy and Europe and then subsequently New York. We had time to think about, is there a better answer, or do we have an alternate way that we can take care of these patients and deliver care?
So about February of this year, we started to see what COVID-19 was doing around the world. And one of the unique things about my position is I get to be imaginative in processes and imaginative in what we're going to do as an organization with the limited resources we have to address the challenges in our rural community. And that doesn't occur in an isolation. It doesn't occur as one agency. It's one of the cool things about community paramedicine is you identify your partners and you bring them all together and we work collaboratively to address the problem. So we started anticipating, we started looking at other areas and the challenges they were facing as COVID-19 ran through their communities. And one of the things we knew we had to do was improve transport efficiency. We knew that utilizing the most expensive form of transport to the most expensive destination every single time was not going to be a viable solution. We also knew that we stood the potential of losing a great portion of our workforce to the virus, either through this or through them being quarantined and things of that nature. So we wanted to reduce provider risk of exposure. We also wanted to expand access to care because we knew that the number one reason that patients don't receive health care is because they don't have access to health care. And that's either because they don't have insurance or because they don't have a primary care doctor or they don't, in our area, a lot of times it's because they don't have transportation. And so we wanted to make sure that they had that expanded access to care. We also wanted to enhance the patient care experience. We wanted to make sure that patients had a unique experience we are a special district, which means we're tax-based, and we want to make sure that our community felt the value of the services that we provided and really saw the value in supporting their community partner, their community entity, us. And then we also saw that with our current workforce, we run 3 ambulances and cover 539 square miles, and there was no way we were going to be able to meet the potential demand of COVID without coming up with a unique and interesting way to address it. And so what we found is through this approach, we were able to take these ambulances and we could split up a crew and have one crew member run one call while another crew member runs another call, and it becomes a force multiplier for us. And we can take one ambulance and double the output of that crew.
So I'm going to walk you guys through sort of a case-based introduction to our solution to COVID-19 and telemedicine in our community. We're going to kind of highlight our approach, exactly what we do from a documentation, billing, and coding perspective, the software platforms that we're using to achieve these goals. We're going to specifically talk about Pulsara, our sponsor today, and why they're a unique solution to this problem. And then I'm going to talk, and James is going to talk a little bit about the future, how we can leverage this solution for COVID-19 into other avenues of healthcare. So we're going to start off with our case. As we develop the system in response to COVID-19, we're going to go through a COVID-19 case. Most of our calls are initiated via 911. So in this scenario, we're going to have a 64-year-old female who has a fever and a cough. Perhaps she has a known relative who tested positive to COVID, and she's worried that she may have COVID-19. So she has initiated a 911 call, and our PSAPs are dispatching that call to UPass Regional Health Services District. And our UPass Regional Health Service District EMS provider will get the notification from 911 along with the patient's identification, information, address, and phone number, and they will initiate a telehealth consult with this patient. This is done in one of 2 avenues. So if the patient has a smartphone or a tablet or a computer, they can receive a text message like you see on the right side of the slide here that instructs them to click on a link to create their telehealth portal or their telehealth visit. So our EMS provider has created a case in Pulsara, and they have notified the patient. Now, a lot of people will ask, well, most elderly folks don't have a tablet or a computer. It turns out that that's not the case, even in our very rural community. But occasionally we do have internet connection or phone problems, and so we can also dial in directly to a landline and initiate this visit before arrival over the phone. All through the Pulsara app. So you can do the telehealth face-to-face visit video, or you can just use a basic phone connection that connects with your patient. And so our paramedic here that you see in the big screen is connected with our patient that you see in the top right. This is into the classic video connection through Pulsara. This may also just be voice, as I said before. And they can attain an initial impression, and they can do a little preparation before they arrive. So we are concerned that this is a potential COVID-19 patient. And so our paramedics have the opportunity to instruct the patient to place a mask on themselves, to wash their hands, perhaps to move to a part of the house that they don't typically cohabitate in. So they may be asked to meet them on the front porch or in a garage or a utility room, in a place in the home that isn't, developed a high viral load or viral titer. So sort of prepping for the arrival of EMS before they even get there.
And then once we arrive at the home, like Matt said, we're going to meet them in an area with a low viral load that's safe for the patient and safe for the provider. And then once we're there, we're going to introduce ourselves, obtain permission from the patient to assess and provide care. And in this case, we're going to assume that the vital signs are all within normal limits and there's no remarkable findings in the secondary examination. You'll notice on the right side, there's a triage tool. And this is the tool that we utilize for any emerging infectious disease patient. And that's just the terminology we use to identify potential COVID patient. But this could be any other future emerging infectious disease as well. And we're going to ask the series of questions. On the left, you'll see the guideline, and we'll ask a series of questions to stratify the patient into one of three categories. They'll either be green, yellow, or red. And if the patient stratifies in the red risk category, and these are basic, mostly physiological criteria, so abnormal blood pressure, abnormal mentation, poor vital signs, poor blood pressure, things like that, those patients will benefit from immediate transport to the emergency room. So we don't delay care, and we transport them immediately to the emergency room in that situation. It should also be noted that there is real potential here to eventually turn this into a tool where we could alternatively designate them as a direct admit patient and bypass the emergency room altogether. And ultimately, that is our goal. But we have to have solid proof of concept first. So the next step is yellow priority patients. And if they fall into that yellow priority, then those patients need a telehealth visit where we team up with the physician and we do the telehealth visit. And then finally, we have the green category where they're stable, their vitals are stable, they have no high risk criteria. And so these patients are going to be okay to stay at home without a telehealth visit, but they will need some follow-up, and they're going to need some social support. So we're going to get them set up with a safety net with Health and Human Services, make sure that they can get food and things of that nature. And both of these client sets, because we've teamed up with public health, both of these client sets will actually also get a COVID-19 sample collection and testing completed right there in their home. So we'll complete the test and then send that off to the state lab for evaluation and then get back to them with results in a timely manner.
Okay, so James went through a patient, and in our case, let's say that she selects him as yellow. So we would like to initiate a telehealth or virtual visit. There's a couple of key documentation things that have to occur in order to generate a billable encounter and to meet HIPAA and CMS requirements. So in your handout series attached to this presentation, we actually included the documents that we utilize here in our community, but our EMS agency has a consent form for a telehealth visit. The physician group, my group, emergency medical specialist, has a consent form for the telehealth physician portion of the visit. We also have a billing disclosure or a billing document capture consent form. This is interestingly also included in your attachments, but this is interestingly was a big hurdle initially for us because as ER docs and EMS providers, we're not used to talking to patients about cost and billing. But with a little training and education and a relatively straightforward form, we're able to communicate clearly with the patient the cost associated with the telehealth visit as opposed to the cost associated with transport and an ER visit. The patient will sign this form. Additionally, all of these forms are then photographed. So Pulsara, as a unique communication solution, is able to take HIPAA-compliant photographs, and these are then loaded into the patient encounter within Pulsara. Additionally, what we will do is have James complete a full history of present illness and physical exam. So on the right side of your screen here, you'll see a basic paper T-sheet. James or our community paramedic team will fill out this entire form and also take a photograph of this and load it into the Pulsara HIPAA-compliant platform.
You will also be provided a copy of this in the handout that you receive related to this online training today. And I want you to notice in that middle section, there's some psychosocial questions and some questions about social history. And typically speaking, in a traditional 911 paramedic call, this is not information that we would gather. So this includes social history such as smoking history, drinking history, risk exposure, do you have a safe place to live? We utilize a tool called the SBIRT, or Screening, Brief Intervention, and Referral to Treatment, to identify risk for substance use disorder, depression, and suicidal thoughts. And then we also do some risk stratification for pediatric patients around immunizations and things of that nature. The reason we do this on these calls is a lot of these patients aren't going to be going to the emergency room, And so they lose that safety net that they sometimes would have in the emergency room. And so we wanted to maintain that safety net to identify patients who are at high risk for suicidality and substance use disorder, so that we could still navigate them to definitive intervention for those issues as well.